My name is Heather Cormier, and I'm a student at Maryville University, nursing class 612. I'm here today with Philip to do my head-to-toe assessment. Before coming into the room, I've asked Phil to empty his bladder and to change into some comfortable clothing. We did take a full set of vital signs with a blood pressure of 134/86, a pulse of 66, temperature of 98.4, respirations 22. He is 69.5 inches tall and weighs 175 pounds. Prior to coming into the room, we did assess his vision, which was 20/20 on both the Rosenberg, testing his near vision, and the Snellen chart for distance. As he walked in, I did notice that his gait was steady and even where he was able to move about freely without any assistive devices. I'm going to start my head-to-toe assessment by inspecting the patient's head first. It appears that the patient's head is symmetrical to the remainder of his body. I look at his eyes, nose, and mouth, and do note that the patient's eyes and nose and mouth are all symmetrical to each other. As I move into the head, I am going to palpate the scalp. I notice that it's freely movable. There's no nodules or masses or lesions noted. Is there any tenderness? And there's also no depression. The hair is evenly distributed throughout. It is coarse and black in color. There's no tenderness noted. So I'm going to move down a little bit into the actual facial area of the patient. But before we go there, I'm going to test cranial nerve number 1, which is the olfactory cranial nerve, by asking the patient to close his eyes and smelling this essential oil. Alrighty, and what is the scent?
Spearmint.
Spearmint is the essential oil that was used, and yes, that is correct. So as we go down, I will move down into the face. I'm going to check the patient's sinuses, the frontal, the ethmoid, and the maxillary sinus. I'm going to palpate. Please let me know if you have any tenderness. Alrighty, and then we're going to move on, assessing the cranial nerves 5, 7, and 12, which are the trigeminal, facial, and hypoglossal. I'm going to ask the patient to go ahead and clench your teeth, puff your cheek, smile, wrinkle your forehead, close your eyes, and stick out your tongue. Can you move it to the left and to the right? This is evidence that the patient's cranial nerves 5, 7, and 12 are intact. I'm going to move down a little into the patient's eyes. As I look at the patient, I know that his eyes are symmetrical, noted center in his face. His eyelashes do extend outward and upward, and the hair distribution to the eyebrows is noted evenly above the eye. There's no periorbital redness or edema. I'm going to lower the lid where I notice that the patient does have a white sclera and pinkish red conjunctiva that is moist with no drainage. I'm going to palpate on the eyelid and the lacrimal apparatus. Is there any tenderness noted? All right. I'm going to assess cranial nerves 3, 4, and 6, which includes the ocular, trochlear, and abducens. I'm going to check the patient's pupils to light. I'm going to actually turn off the light. I'm going to ask the patient to look at me, and I'm going to bring in the light. And the pupil does constrict to the light, and it's equal and reactive to accommodation. I'm going to check the patient's corneal field of vision. And I'm going to ask you to follow my pin line with your eyes. There was no extraocular movement or nystagmus noted while assessing the 6 corneal fields of gaze. As we move along, I'm going to use my ophthalmoscope and I'm going to assess the patient's red eye reflex. All right, just look ahead for me. Red eye reflex noted in the left eye. And great. Also noted to the right eye. At this time, I'm going to ask the patient to do a confrontation test where you are going to cover your right eye with your right hand, and I'm going to also cover my right eye with my right hand. At this time, I'm going to take my left hand and move it into your peripheral field. Please let me know whenever you see it.
Okay.
Great. And we're going to use the other hand. Cover your left eye. Excuse me.
Okay.
Great. All right. So we do notice that the patient's vision is within normal limits. Moving down into the moving over into the ears. I do notice that the patient's ears are attached to the head. The color is symmetrical to the patient's neck and face. I'm going to palpate the auricle and the pinna. Is there any tenderness or masses? All right. And it appears to me that the patient's ears are symmetrical with no deformities or nodules noted. I'm going to use my otoscope and take a look into the patient's ears at the tympanic membrane. I'm going to pull the ear up into the back, and as I use the otoscope, I notice that there is very minimal cerumen noted to the patient's ear canal. There's no drainage noted. The tympanic membrane is translucent and it is gray in color. I'm going to also do the same thing on the right side. Perfect. Same findings in this ear, minimal cerumen noted, no drainage, and the tympanic membrane is translucent and gray. We are going to use the whisper test, the Rhine test, and the Weber test to test cranial nerve number 8, which is the vestibulocochlear cranial nerve. So I'm going to step to the patient's right side and whisper something and see if he's able to repeat it after me. So as I step here.
T9.
Very good. And as I step onto this side of the patient, I'm going to also repeat.
S4K.
All right. We're going to move into the Weber and Rhine test using the tuning fork. I'm going to strike the tuning fork to my hand, and I'm going to place it directly on top of your head. Please let me know if the sound is radiated to both ears, okay? Very good. So that is a positive Weber test. I'm going to move on to the Rhine test, which is going to assess conduction, air versus bone conduction. I'm going to use this, strike it to my hand, place it on the mastoid bone. Once you stop feeling the vibration, let me know, and I will put it in front of your ear, and you will continue until you can no longer hear the sound coming from the tuning fork, okay? Typically, air conduction is greater than bone conduction. All right. So the Rhine test was positive for the patient's left ear. We're going to go ahead and do it for the right. All right. And that was noted that the Rhine test was positive for this patient. He has adequate hearing in both ears. Moving down a little bit to the patient's mouth, I'm going to assess his lips, which I noticed to be symmetrical. There is no lesions, there are no dryness, anything noted to the lips. They are reddish pink in color and moist. I'm going to ask you to open your mouth. Okay. Tilt your head back a little. I'm going to take my pen light and look into the palate. And the hard and soft palate are both intact. As I look around the buccal mucosa, I do notice that the patient's buccal mucosa is moist and pink without any lesions or open areas noted. As I lift the patient's lip and notice around the gum line, I do notice that the patient has no notice any lesions or abrasions or anything, no signs or symptoms of any type of oral cancer. The patient does have his own teeth. There are a few fillings noted from past cavities for this patient. They're filled with both silver and white fillings. I'm going to ask you to open your mouth, stick out your tongue. The tongue is moist. There's no cracks noted. Lesions, can you move it to the left, to the right? It's freely movable without any complications. As a patient does stick out his tongue again, I'm going to ask him to say ah. We're testing for cranial nerve number 9 and 10, which is the vagus and the glossopharyngeal. So stick out your tongue for me and say ah. And when the patient says ah, his uvula does descend into the top portion of his mouth. I'll now test the patient's gag reflex using a tongue depressor. Open. All right. Very good. The uvula is midline, and the tonsils are present at approximately a 2+ grade. There is no odor noted from the patient's mouth. All right. As we move down into the patient's neck, I do notice that there are no deviations noted to the neck. It appears that his trachea is midline. Excuse me. As I palpate along the midline, I do feel the trach being midline with no masses or is there any tenderness noted? Alrighty. I'm going to use my pen light. There is no jugular venous distension noted. Alrighty. I'm going to go ahead and go from behind and palpate for your thyroid, okay? What I'm going to have you do is, while my hand is here, I'm going to have you swallow. Great. And one more time. Great. Alrighty. It appears that your thyroid has no lesions or nodules noted. Okay, just to check your ability to move and cranial nerve 11, we're going to get you to do some active and passive range of motion. So I'm going to have you tilt your head from side to side. Okay, turn your head from side to side. Alrighty. Go ahead and then head forward and backwards. Okay. And in order to assess cranial nerve number 11, which is the spinal accessory, I'm going to put force down on your shoulders, and I'm going to ask you to just lift them up. Okay. So go ahead and shrug. Okay, and down. Right. Good. Your face, push against me as I push. Okay, and one more time. Good. While I'm in the vicinity of the patient's head and neck, I'm going to go ahead and palpate for his lymph nodes. We're going to start with the pre-auricular, which is here, post-auricular, occipital, tonsillar, submandibular, submental, anterior cervical, posterior cervical, supraclavicular, and I'm going to assess the axillary. Okay. There's no lymphadenopathy noted upon palpation for this patient. I'm going to go ahead and auscultate both the carotid artery and the thyroid. So at this time, I'm going to do the carotid. I'm going to ask you to take a deep breath, and hold it. Okay, and the next one. Perfect. Okay, I'm going to go ahead and assess the thyroid. All right. There's no positive, we're not positive for throbbing, thrills, or bruise upon auscultation. I will now palpate the carotid artery. I'm going to do it one at a time to not occlude any blood flow to the brain. Okay. At this time, I'm going to assess the precordium. So I'm going to listen to the patient's chest. Aortic, pulmonic, Erb's point, tricuspid, and mitral. Which there's no deviations noted while assessing the patient heart. I'm going to view the anterior chest. And as I look, there's no evident lesions, bruising, anything at this time. I do see some old scars from what appears to be a laparoscopic cholecystectomy. The patient's breathing, the rate is normal. There's no accessory muscles that are being used. Okay. As I move to the posterior chest, the anterior chest as well, the color was equally uniform, with again no problems noted. The posterior chest is equivalent. There's no abrasions, lesions, no tenderness noted upon touch. There's no accessory muscle being used for respiration. While I have the patient's shirt up, I'm going to check for tactile primitives. I'm also going to check for diaphragmatic excursion and the tactile primitive. As I place my hands here, I'm going to ask you to repeat the word 99. 99, 99. Perfect. Alrighty. And take a big deep breath. Great. Alrighty. So right at this time, I'm going to have you take a deep breath and hold it in. And I'm going to percuss for the diaphragmatic excursion to be able to find the change in sound. All right, and I'm going to go ahead and mark it. All right, now let your breath out. Take a few big deep breaths. All right, and we're going to take a deep breath and hold it. All right, and this is noted to be approximately 3 centimeters, which is within normal limits. All right, and the thoracic expansion, when my hands were placed and patient took a deep breath, it was equal bilaterally. I went ahead and percussed for the diaphragmatic exertion. I'm going to ask you to lay down at this time so I can assess your abdomen. All right. Can you place your hands above your head? I'm going to lift your shirt. I'm going to auscultate for vowel sounds in all 4 quadrants. Listening for typically 3 to 5 minutes. Great. There is adequate vowel sounds noted in all 4 quadrants. At this time, I'm going to percuss until I find the splenic and the liver border. And it's noted here. And the liver is noted here. I'm going to lightly palpate on the abdomen. Okay, and I'm going to deeply palpate. This may be a little uncomfortable. There's no lesions. Is there any tenderness? There's no masses noted. Okay. As I continue to assess the patient, I do notice that he has what appears to be an umbilical hernia. For now, I'm going to feel here using my thumb and my forefinger for the aorta for palpation. And I'm going to auscultate for the aortic artery. Left renal. Right renal. Left iliac. Right iliac. Left femoral. And right femoral. At this time, I'm going to palpate for the liver, placing my left hand under the patient's back. Where the liver is not noted or palpable. It is noted but not palpable. And so the spleen. The spleen is also not noted. While I'm on this side, I'm going to go ahead and attempt to palpate for the left kidney, which is also not palpable, and for the right kidney. Great. As you sit up, I'd like for you to use your abdominal muscles to get up. Perfect. Abdominal muscles are noted without any weakness. So I'm going to move on to the patient's extremity. I'd like for you to extend your arm. As I palpate on the patient's extremities, I do notice that the muscle tone is intact. I do notice that the patient's skin temperature is equal bilaterally. It's warm to touch. I'm going to push down on your arm. So I want you to push up and vice versa. Okay? Great. Muscle strength is noted. I want you to grab a hold of my fingers and squeeze as tight as you can. Great. Good strength noted, equal bilaterally again. We're going to check for capillary refill, which is good. It's less than 3 seconds in both hands. We're going to also check for clubbing of your fingers. I want for you to take your fingers and put them nail to nail, please. And a small diamond is noted. Move on to the next finger. Great. And the next one. And last one. Great. Great. All right, perfect. While I'm still focused on the upper extremities, I'm going to use my hammer to feel for the patient's brachial reflex and radial reflex. So I'm going to ask you just to place your arm in my hand and to relax. Great. Okay. Great. Great. Okay. And here, just relax. Great. And both reflexes are noted. I'm going to now palpate both the brachial and radial pulses. Good and strong. A good 2+ pulse noted. And before I move into the sensation portion of both extremities, I'm going to go ahead and assess the lower extremity, okay? All right, go ahead and elevate your legs for me. All right. I do notice good muscle tone in both legs. Okay. I'm going to pull up on your legs and you push down and push up. Great. Great. Okay. The temperature is equal bilaterally. His feet are kind of cold, but it's related to the temperature in the room. I'm going to feel for the dorsal pedal pulse on both feet, which is strong and 2+. And for the posterior tibial, and lastly for the popliteal pulse. The color is uniform throughout both lower extremities. There's no swelling or edema noted. The hair is well distributed on both upper and lower extremities to both areas. Capillary refill to the bilateral feet is less than 3 seconds. Now I'm going to test the patient's sensation using a soft and a sharp object. I'm going to ask the patient again to close his eyes. I'm going to touch you on your arms or your legs using either the sharp object or the soft. I ask that you identify the place touched and if it is a short or false option. Okay?
Short from my left wall. Sharp from my right hand.
Okay.
Sharp from my left hand. Sharp from my right wall.
Okay. Great. All right. Again, I'm going to use my reflex hammer and I'm going to check the patient's reflexes and his Achilles tendon. Great. While the patient's in a 90-degree angle, I'm going to hold his foot in my hand and strike the Achilles tendon with a good reflex noted, meaning that his Achilles tendon is intact. Great. All right. I'm going to ask the patient to stand up and lean forward so I can assess your back. As the patient leans forward and as I palpate along the patient's back, I do not feel any lesions or tenderness once again. The spine looks to be midline without any kyphosis or scoliosis. Scoliosis noted. I'm going to ask you to stand up. Once again, I would like for you to stick your hands out like this. Close your eyes. Okay. And balance yourself on one foot. Okay. And down. And use the other one. All right. Great. Okay. No abnormalities noted. He's a little off balance today. So that concludes my head to toe assessment, and all cranial nerves have been checked throughout this assessment. Thank you.